Okay, so this is going to be for the catch-up week that we did the last Monday that we were in class. It hopefully you guys can find it. I'm going to put it in the announcement that I posted it because I don't want you guys not to see it. I'm adding it to the bottom of that week. I can't remember exactly the week it was. So Monday we did a review. Thus far, we've really gone over therapeutic communication, as well as schizophrenia and some depression stuff, right? Those are like the three main things. I did another video on depression, so this will have, it will incorporate it. What I'm gonna do, and please, please, please make sure you watch that MAOI video that I posted, even though, well, obviously it's homework as well, and really understand it, because those questions and Nurse Mike in general, that's what, okay, I was trying to remember. That's what I'll do. I'm going to post that video. So there's a guy named Nurse Mike who does videos as well. I'm going to post that. And the reason why is because I explained in class on Monday that we cannot possibly go over everything. And so I'm focusing more on the SSRIs and the SNRIs, not the tricyclics and the MAOIs. However, of course, we need to know the importance of the MAOIs and all the side effects, which we already talked about, and the video show. So that's what it is. So we're going to quickly go through. I added, as you can see, and we're just going to go through. I'm going to skip like the 5158, like stuff like that, the ones that we've gone over several times, or say them very quickly. And then there are a few new ones. Some of them I'll just skip completely because we haven't gotten to that part yet. And then I'm actually going to do the entire Jeopardy. We didn't do that in class. And again, I will skip the ones that aren't important. But for example, one of the questions had to do with grapefruit, and what was the most common thing that interacts with medications? Grapefruit. We should know that. So this will be probably, I think I can get through this within 30 minutes. Again, this is a recap. This is for you. If you don't want to watch it, you don't have to. This is just for your help, because I know class does go fast and I have to talk fast and it can get very confusing. So let's get into it. So 5150 we know is a 72-hour involuntary or voluntary hold for one of three reasons: either danger to self, danger to others, or gravely disabled. We know that a 5250 is an extension of a 5150 for up to 2 weeks, and that is not voluntary. That would make sense, I would hope, because at that point they've deemed the individual to not be competent. So that's why they can't say, oh, well, I checked myself in, now I can check myself out. So keeping that in mind, that an involuntary hold can turn into, a voluntary hold, if you went in on your own, can turn into a involuntary hold. And for the same reasons that we mentioned before, the same three. Next one, being conserved, again, one sentence: not being able to make sound decisions for oneself, so someone else does it for you. That's all I want you to get down and remember. And also, I said in class, just as a reminder, when you're studying for your boards, a lot of this stuff is going to come up too. So that's why sometimes I'm trying to keep it shorter so you recognize it, and will hopefully then it will spark a memory while you're studying, and it will make it much, much easier as well. And it will help you in clinical. Affect, when I say affect, that has to do with your facial expressions. And that becomes very important, especially in clinical. You'll learn more about that and what that means. And just, for example, if somebody had absolutely no facial expression, that's called a flat affect. And you'll learn the other affects when you are in clinical with me. Psychosis, we all know, it was in the last test, hopefully. Psychosis is a detachment from reality. A neurotransmitter is the way our brain communicates. And again, I know that seems a little bit kind of like high school. Why are we learning this again? But neurotransmitters such as dopamine, norepinephrine, acetylcholine, norepinephrine, all of those are very, very important because it has to do with a lot of the medications if it crosses the blood-brain barrier. So it's important to know if your brain's communicating via these neurotransmitters, it kind of builds that connection on how to remember what medication's going where and why it's doing what it's doing. Next is, we all better know this one. What neurotransmitter is most closely related to schizophrenia? Of course, and I gave you guys back on your last quiz, if you put norepinephrine, serotonin, or dopamine, I did give you credit, because after really thinking about it, it wasn't really a fair question, because they do all have to do something with schizophrenia, but the most related, having to do with positive symptoms, remember, something that's added to your personality, is going to be the dopamine. It's because they have that population has too much dopamine in their brain. How, apparently I can't spell here, but how do antipsychotics work? We know, as I just said, if we have too much dopamine, and that's a large cause for symptoms and behaviors and symptomology that you're seeing, antipsychotics are going to lower the amount of dopamine. What can happen if our dopamine is lowered too much? Unfortunately, we can get, again, I prefer, so tardive dyskinesia, that's more of like the umbrella, it's an umbrella term and things go under it. Tardive dyskinesia would not be wrong to say, but I like to use the word Parkinsonianism. It's hard to say, Parkinsonianism, because it links that with dopamine. And we all know that if you don't have enough dopamine in the substantia nigra in your brain, you're going to have the same symptoms as you would for this. It's just in a different part of the brain. So importance of this is just understanding how antipsychotics work, which we've gone over several times, and that's lowering the amount of dopamine in the brain, hopefully relieving those positive symptoms such as hallucinations, delusions, and illusions, which I also posted a video on, and I hope that was helpful. And why does it happen? We just talked about that. Haldol and either risperidone or risperidol. What are the classifications? So I add in medications here and there. So if I do mention certain medications, I don't want it to freak you out or cause you anxiety. Again, I mentioned it in class on Monday. When you're taking a test in my class, since I do the reviews, just a reminder, I'm also going to put a list of the medications that you need to know. This is just our way of kind of starting to gain that knowledge, and not have it be so overwhelming, because again, we have so much to do and so little time, and I want you to remember certain things. And I pick kind of the most popular ones that I see still being a practicing nurse. So on the floor or unit, if you will. So Haldol as well as risperidol. These are both classifications of antipsychotics. All right. Abilify and Zyprexa are also classified as an antipsychotic. And then I ask, are they newer or older? Now, is that 100% important? I mean, not 100%, but the reason I'm just kind of throwing this out there again, I like to do side notes, is because Abilify and Zyprexa, okay, so they're classified as antipsychotics and they are newer. So they are newer. And why do we come up with newer medications usually? It usually has to do with the fact that the older medications do have side effects. So such as Haldol, you're going to see usually more tardive dyskinesia and those type of, and not with everybody, because again, we all react to medication differently. And maybe something like Abilify and Zyprexa, you may not. It's kind of like why tricyclics aren't used as often. They're not bad medications at all. However, they tend to have more side effects. What is Parkinsonianism? We just talked about that. That means that your dopamine has dropped too low. And this can happen when you are taking antipsychotics, and you will notice, and it's just 3 symptoms that we've talked about this before. They could be tremors. Right. It could be, sorry, my dog just cried. I got distracted. So it could either be tremors, which is a very, very common one. Tongue rolling, that's also a very, very common one. And I mean, just think about it. Dopamine, again, our neurotransmitters do many things. So it's not just one thing, not just this thing. So dopamine has a lot to do with your muscle movements and control of your muscles. So, and I'm sure you watched the video I posted about the side effects and actually watching somebody go through this. And it can be on a spectrum, which I mentioned in class as well, which I had forgot to mention, that every diagnosis is on a spectrum, right? So there can be somebody who has ADHD who could be functional, as myself, and I mentioned that I'm completely comfortable saying that, and I don't need I feel I don't need medication, and I'm functional, and it actually helps me rather than hinders me. But there are some people that possibly, and this is to each their own, it's on a scale where it is really hindering their life, and then they choose, okay, I need medication because I'm on that far of the spectrum. Okay. I just want to throw this out there. I'm not going to test you on this, but I'm going to repeat it very quickly. Why is it usually so our DNA, it can actually change. So your brain and your DNA can be set up for one certain thing. But if it's not exposed to that certain stimuli, it may never happen. So, for example, and this has to do with addiction, and I did mention this in class. Again, this is why I like doing these, because I may remember something, or it could maybe help you understand something that I was trying to say in class that you didn't understand. And that would be, so let's say somebody is predisposed actually to, and I talked about this in the addiction videos and class, but let's say somebody is predisposed to having, it's in their genetic material within oneself to be vulnerable to have schizophrenia, and they smoke marijuana. Marijuana is actually a drug that could potentially, I mean, it's rare. I think I've seen it only once with marijuana. There's only 2 drugs that do it, and we'll talk about that more. I'll tell you, it's methamphetamines. I think twice with marijuana and once with methamphetamines that this has happened, but it causes drug-induced psychosis, and it can last a day, a month, or it can actually turn that DNA replica into schizophrenia. So it turned it on when you would have never, ever, ever had it. You do not need to worry about that now. I'm just trying to give you an example, so hopefully you understand it if that doesn't make sense. So like here, if you have that predisposition for schizophrenia, a lot of the times why we see it in the college years is because what are like usually, not always, but usually the most stressful time of your life while you're in college. So we do see the occasional child or older than this, or I mean, because we can go to college when we're 75, right? So this is usually linked together, and I just thought that was interesting. The compliance part has to do with a lot of time, and this is going to come up with the injection medication that I'm going to talk about for schizophrenia. It's an antipsychotic, which you do need to know. I believe, I can't remember. You're definitely going to see it on a test, but it'll be on the study guide. If it is compliance. We've talked about that. I would say this diagnosis of schizophrenia is the most non-compliant with our medication due to being paranoid, and really that would be a delusion. I mean, they have that fixed belief that potentially you're putting a camera inside of them, or you're trying to do something to them, and they're scared, and it's hard. I can't imagine that feeling that way, because I can. I mean, you never know how a medication is going to react, right? I think a lot of us can attest to that. So imagine that plus having that being paranoid and being nervous and being scared that it's actually you're going to be watching me and knowing what I'm doing, or you're trying to kill me. So compliance is an issue with antipsychotics, which is why unfortunately we do see that revolving door a lot with those who have this condition, because they stop taking their medication and then they end up back in the psych unit, and then they end up back in a program, and it's just kind of does that. But not for everybody. That's why I showed you the 2 different videos of schizophrenia in the beginning of this. Actually, when we were doing the lecture, the one with the TED Talk, and then the one at the liquor store. Stigma, you guys know about, and then treatment we've talked about. So positive versus negative symptoms. This was on the quiz. Just a reminder, I just said it, but I'm going to say it again. The positive symptoms add to, so that's going to be hallucinations, delusions, and illusions. Negative symptoms take away. So that's more, lack of motivation, feeling tired, hopeless, worthless. It's being sad, basically, right? So it's taking away from your personality. So that's very important to be able to distinguish. Hallucinations, we know what they are. And remember, from here on out, we're going to use the medical words. So the first quiz, I let you use taste instead of gustatory. So we know we have visual, olfactory, which is smell, gustatory, which is taste, auditory, which is hearing, and tactile, which is touch or feeling, like on your skin or under your skin. A delusion, we know, is a false fixed belief. And usually we see it having to do with, remember, the CIA, police, religion, that kind of thing. It doesn't have to be that, but that's just, I'd like to give that example because that's usually, in my experience, where the delusions head. That's why we really, really, really stay away from that topic when we are conversing with these patients who are having delusions. And the last one, illusions. It is when we are basically mistaking one object for another, which, again, I made a whole video about this, so I don't want to take up much time here because they do want to go to the Jeopardy. But illusion, so, okay, I have a pen and I think it's a snake, but something must actually be there, right? Otherwise, it's a hallucination. How do we diagnose in mental health? Everybody got this right on the money, and that is a DSM-5. We must have it, and you must fit the criteria to get the actual diagnosis. If you see a DSM-5 when you guys are in my clinical or just in general, please pick it up and take a look at it. I'll try to remember at some point. I have, I think, the older version though here at my house. But anyhow, moving along. So this one, I can't remember if we talked about it in class, but Seroquel, the classification is an antipsychotic, and it's often used off-label for sleep or agitation. So it's sedating. You don't need to open your drug book and get all the information and cause a big ruckus about it. I'm just mentioning it, and it will be, again, on the study guide if I do test you on it, but it is a medication that's often seen. So if you're in anywhere at Lincoln Glen, if you're at the forum, you've probably seen this medication, and you may look at it and you look it up, it says antipsychotic, the patient's not psychotic, and you're like, what? Why are they taking it? Usually now Mars will actually say Seroquel 25 milligrams, PO, HS, meaning by mouth at bedtime, for sleep. So it can be used off-label for sleep. What classification are the following medications? We should know this. We have reviewed this in our depression lecture. So again, I will list the medications you need to know before quizzes and tests. Other than ATI, I may not get all of them, but as I mentioned, I am going to give you something to go by because we may not have covered everything for your midterm on ATI, but I will give you something to kind of go by if on the ones that we have not covered. Let's see here. So what classification? So the classification would be they're antidepressants. And then specifically, what are they? They are SSRIs, selective serotonin reuptake inhibitors. We have talked about this plenty, so I'm not going to take up more of your time on this. What classification is the medication Latuda? We're going to talk about that when we talk about bipolar disorder. So we'll just leave that for now. Which medication? Okay, so this is very important, and you do need to know this. So which medication lasts a month and is used for those who have schizophrenia and is classified as an antipsychotic? So there's actually two forms of this. So this is an injection. It's called Invega, INVEGA. Invega, yes. So there's one that lasts for 1 month and one that lasts for 3. So why do you think that would be important? And we already talked about it in class, but as an antipsychotic, well, exactly what we just talked about. So that would be compliance. And if we can give a patient and hopefully make them feel comfortable enough to get this injection, then they don't have to take the medication, and compliance is going to be much, much better. So again, Invega, INVEGA, lasts either 1 month or 3 months, depending on which one you get. I will not ever confuse you on a quiz or a test. I will be very clear, and I would never put, is it 1 or 3 months or something like that? It would be clear. Name 3 SNRIs that we spoke about in class. There's really only 3 that I've ever seen prescribed, so we should know this, and that would be Effexor, Cymbalta, and Pristiq. You will always need to know that. Which classification does Wellbutrin fall into? So this is a new one that I kind of am introducing. You will see this on a medication list probably for, I already put, by the way, for your midterm for my class, I already put that one up, but you'll probably see this on the final. If not, or a medication, something that we do. So Wellbutrin is what we call an outlier. So it doesn't fit into an SSRI, SNRI, MAOI, or tricyclic. It's on its own, meaning many people do mistake it for an SNRI because Wellbutrin is classified as an antidepressant. However, it only goes to norepinephrine. And we know that norepinephrine, if it's ignited and it's working properly, it will create motivation and energy. And so a lot of people say, oh, it's an SNRI. Well, it's not, because it doesn't touch serotonin. So then it wouldn't fall into that category. So that's why I don't know if they call it in the hospital, but just for, for us, I mean, it's an outlier. So that is what Wellbutrin is. It's an outlier, and it goes to the norepinephrine receptor. Okay. True or false? Most antidepressants can help with depression and generalized anxiety. Absolutely. That is true. We talked about that in class, and it was on a homework assignment that you got, I think last week. And you guys, I think all got that right. So true or false? Yes, absolutely. So again, that's another reason they made more, medications as well, because they noticed, wow, we're noticing that a lot of people that have depression and anxiety and vice versa. However, don't forget, this is generalized anxiety. So if I'm at Great America and I'm getting super anxious, I can't take a Prozac and expect it to help with my anxiety. It's in that moment, it's for generalized anxiety. So that's where we'll get next week, or I guess it's next week, when we're talking about anxiety medications. We'll talk about the ones that are going to help more immediate, like benzodiazepines, like Ativan or something. So yes, this would be true. And it's remembering generalized anxiety. That's very important. Next, again, I'm just mentioning these now, that Thorazine, Clozaril, and Geodon, which classification of medication is this? They are also antipsychotics. And I will put them on a list if you need to know them. I'm trying to introduce you and kind of start getting used to seeing the name and being familiar. That's the main goal. And we already know what antipsychotics do. They all work in the general same way. However, they affect everyone a little bit different, and there might be a reason one is given over another. What classification is Remeron? So Remeron is actually an outlier as well. And Remeron is pretty interesting, actually, in my opinion. I see it mostly used, and I guarantee the other name is I always say wrong, Mirazapam or Mirazatine or something like that. But that's why I call it Remeron. And it does a couple things. So it doesn't fall under a category. Its classification is an antidepressant. However, it can also be given for increasing your appetite and for sleep. So this would be given at bedtime. So if I had somebody come in and they had been depressed for a very, very long time, and one of the things that, they were symptomatic of is not maybe having an appetite. And so they've lost a ton of weight, or I have an elderly patient. We see this a lot with in that population, and they're depressed and they're having trouble sleeping. I mean, not like I'm excited that this is happening to them, but it's like, oh, yay, I can give you one thing instead of having to give you potentially multiple or whatnot. So Remeron classification is an antidepressant. It does not fall under a specific category. It can also be given off-label to help with appetite and sleep. So we always give this one at night because it does cause lethargy. One thing I did not mention in this, but we did talk about in class about Wellbutrin also. So yes, it is considered an antidepressant, but off-label, it can be used to help somebody stop smoking. So they do use it for smoking, the cessate, I can't say it, stop smoking, helps with the cravings. And it can also be used for ADHD as well. And then thirdly, it is the one antidepressant that does not cause sexual side effects. Basically, it's so that I think all of those are important to know. So again, Wellbutrin, it is an antidepressant. It is considered an outlier. It goes to the norepinephrine receptor, so it helps with motivation and energy. And it can be used off-label to help somebody stop smoking. It can also be used for somebody who has had, especially if they've had sexual side effects in the past from other medications, as if they were on antidepressants. And then it can also be used off-label for ADHD. All right. So what are the 3 reasons Remeron can be used for? We just answered, and that is for depression, for sleep, and for weight gain. Why are medications that interact with serotonin contraindicated with those using bipolar? We'll talk about that when we talk about bipolar. What does it mean when I say hypervigilant? Hypervigilance, I think most of us have heard of this or whatnot, but it's very important. I teach you about it when you come to my clinical. And that has to do with, like, if somebody came up behind you, and I am actually pretty hypervigilant. I get scared very, I startle, and if somebody comes up too quickly. So this is something you might see, for example, with somebody that has PTSD, they might be hypervigilant, and that may have to do with the fight or flight system in your body, just being kind of on edge, if you will. Doesn't mean you have to be like that all the time. Just it could be certain times. And almost done with these. That one doesn't matter. Where is 90% of your serotonin? You better know this. It's in your gut. So remember, I don't try to confuse you, but I might switch it and ask you this way or the other way around. So really, and I don't do it to trick you. I do it because I want you to read the question, because I'm trying to train your brain to do that in order to have you pass your NCLEX, right? So 90% in your gut, 10% in your brain. Yay, perfect. Okay, so I'm now going to switch over to the Jeopardy one, and we'll do kind of the same thing, but we actually played in class, which I think is super fun. All right, so I know this looks like, oh my God, this is going to take us forever. It is not. I'm going to skip several of these, but we did not do them all in class either, but we're going to do a few more here. Just because we have time, and if you want to watch it, you can. And again, if you don't have to. And also, I will post that video right after this of Nurse Mike talking about medications, because he goes more over MAOIs and tricyclics. So of course, knowledge is power, and I don't have the time to do it. So if you would like to watch it, you can. All right, so we'll just go down, starting at medication for 100. True or false, all medications will react the same way in all patients? Absolutely not. I think most of us already know that. Some people can take melatonin, something as we kind of look at as very light and simple, and it's great. Other people take it, and for me, it makes me so anxious. I want to rip my skin off. It's like, how does that make sense, right? So it's very important to understand that it's not always going to react the same way. Medications. What can Lexapro be used for? So as I mentioned earlier, so antidepressants can also be used for generalized anxiety. So Lexapro's classification is an antidepressant. It is an SSRI, but what can it be used for? And that would be for, I'm going to skip the answer. It's like I've never played this before. Oh, sorry. It's been a long week. Depression and anxiety. So that's exactly what we said. I didn't put generalized anxiety because I said that out loud, but yes, anxiety. All right, the next one we're going to do is, what classification of medication does Ativan fall into? So classification, it is an brain just went completely blank. Anti-anxiety, And then specifically, it's a benzodiazepine. We haven't really talked about this because that's what's coming up next week. So I figured that this is why this one's called. So I have 2 Jeopardies we're going to do. We have an addiction one that we'll do when we're talking about addiction, and then this one's kind of more general. So this kind of helps prepare for things that are coming up. And I will again skip some of these that are just not that they're not important, but you either definitely know it or it's just not something that we need to talk about. So classification of Ativan is an anti-anxiety, but specifically, what is it? It's a benzo. So antidepressant, specifically benzodiazepine, which we will talk about more Monday. All right, 400. So this is important. Name the medication that is classified as an anti-seizure medication, is used for anxiety, sleep, nerve pain, and can be used up to 4,000 milligrams a day and is not considered habit forming. I've talked about this medication. I usually use it a lot with my examples. I'll talk about it as well next week on Monday. So this would be gabapentin. So remember, what is gabapentin actually classified as? It's classified as anti-seizure. Often, most of us who have been in the hospital thus far or in a clinic or many different things, or a family member, or maybe even yourself, we associate it with nerve pain because it can be used off label for nerve pain and neuropathy, not just for those who have diabetes, but it could be just if you have nerve pain. So again, gabapentin, you will definitely be tested on this for sure. It's an anti-seizure medication as far as classification. It can be used off label for nerve pain. And then for the psych use, anxiety, sleep, agitation. I mean, it does many things. So we call it the umbrella drug. And as you can see, it has a very wide therapeutic range. You can take up to 4,000 milligrams a day. You might hear some say 3,600. So it's 3,600 to 4,000. I use 4,000 milligrams a day because that matches Tylenol, and it just kind of keeps it again to where you're able to remember it. So, and it's not considered habit forming. You will learn what that means. And I'll talk much more about that when we talk about addiction. So gabapentin. All right. Last one on this one is, what neurotransmitters do SNRIs interact with? Well, I see an S and I see an N. So it's going to be serotonin and norepinephrine. Serotonin has to do with well-being. Norepinephrine has to do with energy and motivation. Excellent. All right. So let's go down the next column here. We're going to definitely skip some of these. Just for fun, the hormone that helps us regulate sleep, that's melatonin, and more of that starts to disperse in our brains as it gets later in the day. That's why if you work knock shift, your body kind of really has to adjust. And that's why melatonin, which you can buy over the counter, can help you sleep. And if somebody's kind of nervous about just taking anything, that's the most, what I would consider one very natural way to do it, because you're already producing this in your body, right? What is the brand name for diphenhydramine? It would be Benadryl. Again, I'm just going over these. You will know what you need to know, but at least you're seeing it. So diphenhydramine is the other name for Benadryl. A sleep disorder that causes one to stop breathing during the night, we know that is sleep apnea. And the reason why I put that on here is because this can actually cause, it's been linked with evidence-based practice. It's been linked with the potential to contribute to depression, just like your thyroid being off and whatnot. That's why I always say rule things out. Don't just look at, oh, they're sad, that must be their serotonin or norepinephrine or one of those. It could be caused from something else happening. So getting blood tests and doing these things and looking at the whole picture. Name 3 prescription medications used for sleep. We're not going to do that. I mean, I can name some for you. Lunesta, Ambien, and Trazodone. But again, we'll talk more about that when we talk about sleep. I think I talked about Trazodone in this one actually. Or no, I talked about it in the depression one. So you already knew that one. A sleep medication that, oh, here we go. A sleep medication that was originally made for depression, but is now used for sleep and is not considered addictive. So we should know this one because we talked about it. We don't use it for depression because we would have to take 400 to 600 milligrams a day. So if you watched that video that I made the week we did depression, which was the week before last. It is trazodone because we can just use a little bit of it. It's not considered habit forming. And remember, it does not help with feelings of depression because we're not giving 400 to 600 milligrams a day because you would just sleep all day, right? We're giving you a much smaller dose, like 50, 100, 150, 200 milligrams. So that's why it's off label. So the classification of trazodone, antidepressant. The actual off label use would be for sleep. So psychiatric diagnoses, name 2 symptoms of depression, lethargy, lack of appetite, or increased appetite. There you go. There's many people present very, very different. Sadness, crying. Mania and depression are symptoms that go together as what diagnosis. I'll just answer this one I did in class as well. It would be bipolar disorder. So a lot of people in class, the day we did it, first thought schizoaffective. But remember, schizoaffective is when you're having symptoms that are mixed with bipolar and schizophrenia. Mania and depression are bipolar disorder, which will make much more sense when we actually do the lecture for bipolar disorder. True or false, depression and anxiety are often associated with each other. We just talked about this. This is why I like that we did it this way. And I did it kind of, obviously, as I always say, there's a method to my madness because we are kind of answering questions that we just talked about in the Quizlet. And I've lectured on. So it kind of hopefully brings it full circle. So we know that this is going to be true. All right. True or false, schizophrenia can only be treated with medication. So remember, way back when I talked about certain disorders happen for a reason. So this one is actually true. It's because it's chemical. Unfortunately, you can't just go to therapy and I think therapy is important once you're stable, but that is a chemical disorder. I'm trying to think. Other ones, like I said, can be triggered. So you could be totally fine and then, have PTSD from something. And then now you have an anxiety disorder because anxiety, PTSD falls under the category of an anxiety disorder. Again, we haven't talked about anxiety yet. We'll talk about it next week, but that is true with schizophrenia. And I don't really think, to be perfectly honest, it's super important for you to know all of this. It just happened to be on here. And I think, but what I do think is important is the bigger picture, that some things are caused from chemical imbalances. Some things are caused from experiences such as trauma. Some things are caused, there's different reasons why we are maybe like I talked about, circumstantial depression versus, like if a pet passes away or a loved one, that it could be circumstantial. Of course, most people are going to feel very, very sad and depressed and may not want to get out of bed for a week, but then, okay, then they're starting to feel better and things are okay. Where it's not chemical, and I'm not saying you have to take medication. I always am very straightforward about that, but medication could be very, very helpful. And of course, usually evidence to show that therapy and medication together can be the best outcome, but not everybody believes in one or the other. So, we have to educate, and then our patients make their decisions. And there's other ways, like I mentioned in class, holistic. It's not just one way. We definitely want our patients to buy into their treatment. If my patient is so against taking medications, I'm not going to try to manipulate them. I'm going to teach them, and hopefully they'll make the decision that's best for them, because, we want to meet them where they're at. This one's very important, I think, because it's about assessment. What are somatic symptoms? So usually they're called psychosomatic symptoms or somatic symptoms. That has to do with so let's say you're anxious. So that would be, it's interesting how they call this or why they call it this, but that's the psych part of it, right? And then somatic is how your body may be showing from that. So if somebody's anxious, it means the physical aspect of what could happen. So if I'm anxious, usually I get sweaty palms, You might have palpitations, increased respirations. You may get very, we're almost where you, depending on how panicked you get, stomach upset, vomiting, even depression. Again, everyone's different, right? They're going to manifest it differently. Depression, just a couple somatic symptoms could be constipation, diarrhea, lethargy, things like that. So you're somatically able to see it. So that's important because you're looking at the patient and that's assessing, right? Muscle pain, if you're so anxious, you're just, constantly kind of almost clenching your jaw, or your back is super tense. Most of you are probably feeling this right now. Okay, not laughing at you, but just in nursing school is, yeah, I don't have to tell you. All right, that's an important central nervous system. I just put that in there because a lot of medications work with the central nervous system, but we'll just skip that one. We'll skip this as well, but serotonin is a big one where I would never ask you that question. We already know this. How does our brain communicate? Neurotransmitters. Name the part of the brain that is responsible for impulse control, personality, and making good decisions. This will be important for addiction, so we will go over it again. And again, please, I hope you're not like writing. We did this on Monday. You'll have a study guide. This is just, again, having you look at it, see it, talk. I add to it. This is important to know, and just in general, of course, but also for addictions, it's going to play a big role. So if I asked you in class on Monday, okay, guys, name 3 things that the frontal lobe does, you can say impulse control, personality, and you can say impulsivity, making good decisions. All of those are right. So your frontal lobe. The protective barrier to your brain, to let things in, we know is a blood-brain barrier. Some things are permeable, some things are not. True or false, Tylenol can be toxic on the liver and cause liver damage if taken over a certain amount of time. Of course, we know that. So ibuprofen, which is an NSAID. So NSAIDs they can affect the kidneys more, and acetaminophen, Tylenol can affect the liver more. Just food for thought. Okay, so this is important, and this is one that I saw. That's why I decided to just do the whole thing. So what fruit often can interact with several medications? So if you really looked at, several, not just psychiatric medications, it will say on it, don't take with grapefruit. And the reason being, it does one of 2 things. It either speeds up how the medication's working, or it slows it down. So the metabolism of it. And it's grapefruit. That's the answer. And not orange juice, but grapefruit specifically. So that can be, I've never really seen this, but when I owned the residential, I did not actually allow any grapefruit in the house. Nothing, no juice, no grapefruit. It just to avoid, right? Because I can't possibly remember. And some are going to be more sensitive to others, or what if they don't metabolize very well? Who knows? So I want to be really, really careful and make sure that my patients are safe. But just an example of this, for example, let's say Ativan, and I don't even know which way it goes for them, the medication. So that's why I'm just like that. That's why probably the pharmacist wouldn't either. I'm just being honest. That's why they just put it on there when they know that it could possibly have an interaction. And look at your book. I guarantee most of your medications will say avoid grapefruit. In my personal opinion, a lot of them would have to probably have a copious amount to have an effect, but you know what? Hey, let's play it safe, right? So if we give somebody, let's say Ativan, which is sedating, for anxiety, and let's just pretend that grapefruit slows down the metabolism, and then they're taking another dose because they're in withdrawal from alcohol, it could potentially build up in their system, cause more sedation, and then potentially more falls. So that's why it's important to know. And again, I'm picking out like the big things, just like that's why I posted the MAOI video, because it's important to know to avoid, fermentation foods, or foods that are fermented, aged cheeses, chocolate wine, all that kind of stuff. So I'm picking the big things. So this would be something that could show up on your NCLEX. So grapefruit can either slow down or speed up the metabolism of a medication. Or do nothing, just depends on the medication. The liver breaks down medication in order for it to be able to do what if it needs to do in the body. This is called what? We should all know it, metabolism. So what I find interesting, and this is a side note, is that, for example, let's say the dose of medication I can give you, I'll just give an example of a medication for addiction that you'll learn about. So you actually only need like 13 milligrams of it for it to be effective if it works for you. However, you take 50 milligrams. Why do you take 50? Because your liver breaks down an amount of that medication. And I'll tell you when we get there how we know this. And if I just find it fascinating. So I think that's important to know. You know, patients could ask you this, and just in general, you're all very inquisitive. And I was surprised. I just never had thought about that before, years and years and years ago. And then I'm like, wait, this makes sense. So that's why sometimes we will take a higher dose than we actually need, because we know that the liver is going to break it down about this much, and then we get our actual therapeutic dose. Again, please don't be writing all this down. You will know what you need to know. A lot of this is just to kind of bring other things together, and hopefully as we continue, as I said, things will start to click and fall into place like a puzzle. We know the answer to this. Why do most people that start anything that has to do with serotonin have stomach aches? Because 90% of it is in your gut, right? And it's not just going to stimulate your brain, serotonin, it's also going to stimulate your gut as well. So now that I'm thinking about it, I may have actually already posted that Nurse Mike video. If I did, I'll go back and double check. If I did, it would be under actually, I'm almost positive I did. It's under the week of depression. And that one has to do with like the MAOIs, all four, but the ones that I don't cover, of course, I would like you to see. And he may explain it in a different way. And he gives mnemonics, and the fact that he is able to kind of give you those tips and tricks, and what he finds are, often questions asked on the NCLEX, which is very important. Where's the liver located? That will be important when we talk about addiction. It's the upper right-hand quadrant. Your stomach is the left. All right, and now we're almost done, guys. Diagnoses. What does OCD stand for? It stands for obsessive compulsive disorder, and this falls under an anti-anxiety. It does fall under an anxiety disorder. So if one is diagnosed with OCD, it is an anxiety disorder. Like I said earlier, I don't think it completely matters that, like have this big chart and try to memorize it all. I think that just makes it confusing personally. But understanding the reason it can be important to know that is because understanding why do people maybe that have this disorder in that population do rituals or do certain things. They do it to help control their anxiety. So that would make sense and make that link. That's probably why I know that Miss Berkeley teaches it that way. So there's that method. And I do plan on at some point posting one, as well as posting a whole big list of medications and their classifications that I have. I just need to find it. I think I know where it is though. So OCD, and we'll talk more about that as well. Cigna, that's an insurance company. Stigma against mental health. We've done a lot of talking about that. The number one thing I always say is a potential, and this can be cultural, it can be just a personal belief. It could be many, many, many things. But my biggest thing that I always say is when someone's depressed, they say, just get off the couch. What's wrong with you? Why can't you just be normal? Just shut it off. And it's like, well, if you've been there, you can't just shut it off. That's like telling somebody to stop having a heart attack, like in the moment when they're having a heart attack, right? Just don't have a heart attack. Well, you can, I've never met anyone that can do that. So please let me know if you have, without medical treatment. Oh, this is a good one. So true or false? And this has to do, we'll talk about eating disorders, but bulimia is often associated with food restriction in patients that are underweight. That is actually false. Most people, except Brandon, he got this right. I remember he was on the celery team that day. He almost said he actually got this right. Like he doesn't get things right. Sorry, didn't mean it like that. But he did get this right. That's absolutely the NCLEX they could try to trick you with something like this. So anorexia has to do more with food restriction. I mean, may only eat 200 to like 500 calories a day. So I can only make up scenarios. So instead of, let's say, and I'm quoting quotations, like somebody, or no, I don't have to do that. Somebody that's not suffering with anorexia may eat a serving of carrots to them, let's say baby carrots, and they're having it with their lunch. A serving to them is, a half a sandwich, 10 baby carrots, and a side of ranch. Okay, cool. That sounds good to me. Or a full sandwich, I guess. Let's make it more realistic. And then somebody, unfortunately, that is suffering with or diagnosed with anorexia might have like one baby carrot. Like that's what they're going to eat. So that's extreme, but I have seen that as well. So it just depends on the person. Again, their spectrum. Bulimia is more about control, and there can be binges. Or there doesn't have to be, and it can be either one makes themselves throw up. There's usually excessive exercise as well with anorexia. We'll talk more about these two things when we talk about food and eating disorders and actually addiction, because bulimia does tap into the reward pathway. If you don't know what that means, you will when we talk about addiction. So bulimia is normally binging and then you're throwing it up. So that way you're not gaining the weight, but usually you wouldn't be able to tell unless there's teeth erosion or things like that. And not forgetting that laxatives can be used as well. But again, we'll talk about that when we talk about eating disorders. All right, 2 left. Hang with me here. Here we go. Method of the madness or madness. Apparently I can't speak today. What book is used to diagnose psychiatric disorders? We all know it's the DSM-5. And this is what it actually stands for. That's why I wanted to put it on here. It's a diagnostic and statistical manual. Do you need to know that while I test you on that? Never. DSM. And I didn't even put 5 because at the time I made this, they were just like changing it. The number. What does dual diagnosis mean, and give an example? We'll learn about this when we talk about addiction. And so I'm just going to leave it at that. So that is that. All right. I hope this was a good review. I guess I won because I was the only one playing, and it said I won because I'm Team Watermelon. I will post this right now, and then I will put an announcement so you guys will know it's there if you want to get a recap. Again, this was our recap week. And then on Monday, we will start anxiety. I am working on your, again, the midterm that you're taking from me after spring break. It's going to be 25 questions. If you open up under that week, it'll already tell you what type of questions I'm going to ask, how we're going to do it. And the study guide's already posted. And then as far as ATI, I will talk to you guys about that Monday and how to prepare for that. I did on Monday, but I will do that again. All right. Hope you're having a good weekend, and I will see you on Monday.